Hi, Kate. How you doing?
Hey, good. Can you hear me okay?
Yep.
All right, perfect. Can I try sharing my screen now and try a video, just make sure it's working?
Yeah.
All right, cool. Let me pull it up.
How you doing, Kate?
I'm well, thanks. We've been super busy. How are other people doing?
Yeah, no, been really busy too. So
Yeah.
I think that's like kind of the everyone's kind of sort of the same deal right now.
Yeah. Yeah, it's been rough because they had cut our nursing budget, anticipating low volumes this year, and now we're like at record high levels that even we didn't have before COVID. It's crazy.
Oh, really? Oh,
Yeah.
so they cut your nursing. That's interesting.
Yeah, they budgeted us for like 10% below what we were like pre-COVID, and now we have more patients than before COVID.
Oh, wow.
Yeah, it sucks.
We had a few, the increased turnover with nursing, so that's where our issues are. So, I think we're trying to hire them. It's just there's shortage everywhere, so then it's hard to get nurses now.
Yeah, same for us too. In addition to just not having enough in general, lots of turnover.
And what kind of stuff are you seeing, Kate? Regular bronchiolitis, or you
All
guys?
the Yeah, I think we've got like just a smattering of all the respiratory viruses. Still lots of croup, hand, foot, mouth, RSV. I think pretty much everything but flu, and lots of COVID. I had like 5 positive COVIDs last night.
Are they sick or just like positive?
Most of them, they were all fine last night. One was having seizures though, an 11-year-old girl with no history. It was weird.
Oh, that's interesting.
Yeah, I'll have to see what comes of that. But one of our local elementary schools is shut because apparently they had something like 200 COVID cases or contacts.
Oh, wow. That's
Terrible. It's like the whole school.
That's awful. Yeah. I'm hoping, yeah, so far so good with my daughter's school. So, but yeah, that's bound to happen. So, it's scary. Has your hospital like arranged for you to get the booster shot yet or not yet?
Yeah, we just got an email today. I signed up for Monday. I
Okay.
heard some other people say they'd already gotten it at like a Rite Aid or,
Yeah, I scheduled
pharmacy.
one for CVS next week because they were not setting it up for us. So I just wanted to schedule it. So we'll give everyone one more minute, then we can start, Kate. All right, good afternoon, everyone. Thanks for joining this Thursday session. Today we have Kate Kasmire, from Penn State Health giving us the talk. So Kate, thank you once again for presenting again, and hope everyone enjoys. You can take over, Kate.
All right, thanks everyone for coming and thanks for having me. For those of you who I've not met in person or virtually, I'm Kate Kasmire. I'm at Penn State Hershey Medical Center. And I have just kind of a smattering of cases today. I was trying to find a theme for it, but you know, in the past, I had mostly stuck with my comfort areas, which is the abdomen is my favorite, abdomen, lung, ultrasound IVs, and seeing so many interesting cases in this collaborative, I was inspired and have been trying to branch out and do some more stuff. So got a bunch of random cases. So here we go. So our first case is kind of a weird history. This was a 16-year-old who came in with leg swelling. He had a history of autism. He was verbal, although didn't communicate his symptoms well. Hypertension, obesity. He had been admitted to our hospital a few weeks prior to this visit with back pain, leg weakness, and he said paresthesias in the legs as well, and feet swelling. He was walking with a cane because he was having so much pain, but they couldn't find anything for it. He had, there was a family history of lupus, so he'd gotten a rheumatologic workup and they didn't find anything. Spine MRI, even had an EMG, had an ultrasound looking for DVT, everything was negative. The only thing that they found was a positive COVID antibody. He had no like known infection, but they tested for that, I think, thinking that there might have been like any cardiac complications. So he had been discharged, was just kind of dealing with these symptoms and came into the ER to us. That the ankle and foot swelling was worsening again. It was in both legs and he was having pain in his feet as well. And now what brought him in this day was he was becoming short of breath, especially with activity and also lying down. He couldn't lay flat. He did not have any chest pain or palpitations, but just the shortness of breath. And otherwise review of systems was negative. And his exam wasn't particularly helpful either. His heart rate was 96, just a little on the fast side. His O2 sat was 95%. His cardiac exam seemed normal. He had no JVD. And his legs, he just had bilateral lower extremity edema. The only thing really remarkable was that the right lower extremity did seem warmer than the left, but otherwise it was pretty symmetric and nothing obvious. He didn't really seem to have calf tenderness that I could tell. So honestly, from getting the history, one of my first thoughts is that it was heart failure from some kind of etiology. And it was kind of unclear. And, I thought of DVT as well, but he had already had that DVT ultrasound before the legs, when he had the leg swelling in the past. So I thought that was a little less likely, but figured without really knowing what was going on with this patient, figured we'd grab the ultrasound and start a quick workup with that. So I started with cardiac, and I apologize, I feel like these images don't look as good as they did on the ultrasound machine, but so this is a short parasternal short axis. And I thought it looked like he had good squeeze, didn't see anything obvious there. And then looking at the IVC, it was a little difficult to see the IVC. This is the best view I could get looking laterally. I couldn't see it in the epigastric area, but it did look like it was about 2 centimeters, so not particularly plethoric. We didn't get a great apical 4 chamber, so I didn't put it in here, but I didn't think that the RV looked bigger than the LV or anything concerning there. And then looked at the lungs to look for B lines. I was kind of expecting to see something, but so you can see here, really nothing on that side, even at the bases. And then on the other side, same thing. So no B lines. And I did not look at the rest of the lungs. I thought afterwards, I could look for like any manifestations of PE or pneumonia or anything, but didn't just look there. So then we moved on and did a DVT ultrasound. So this is starting, the right lower extremity was the one that was a little bit warm. So this is starting up at the common femoral vein. And you can see there, this is where the saphenous is coming into the common femoral vein. So we went up pretty high. You can see the artery there. And on the first view, the resident didn't push it down the whole way, but you can see that the vein is completely compressible right there. So that looked okay. So that's that one. And then moving down to right popliteal. So you can see the artery there, and the vein is just to the left of it on the screen there. And so you can see, so we're doing compression. You don't see any change in the vein there. And you can actually see it looks echogenic within the vein. So it looked like he'd have popliteal DVT. One more time. And then look, moving over to the other side, since you have that swelling in both legs. Here's common femoral on the left with the saphenous there. So that looked okay. And here's popliteal on the left. And it was a little hard to get the compression, but once we got full compression, you can see the artery there and the vein is compressible on the left. And we had also followed down the femoral down as low as we could get in the leg, which is probably about halfway down the thigh, and didn't see anything in the femoral on either side. So, yeah, so that was a nice, like quick evaluation to head us down the right route with this positive popliteal DVT. And then we pursued a PE workup as well. And so that ended up being positive. He had bilateral segmental PEs. They got formal ultrasounds and confirmed the right popliteal DVT. And on the left, I think this explained the bilateral symptoms. Although it wasn't like popliteal, he did also have a thrombosis further down, like in the vessel and the gastrocnemius on the left side as well. So bilateral clots in the legs and PEs. So he got admitted and started on anticoagulation. He did well. He was still hemodynamically stable. They got him on Lovenox and actually didn't find anything with the hypercoagulable workup. And I don't think it's related, but this poor patient needs to stop having more problems. I saw him back in the ER later, and he was doing fine from the DVT standpoint, but was severely ill with new onset diabetes with a DKA mixed HHS picture, obtunded and hypotensive. So it was interesting. Are you guys doing DVT ultrasounds much? I feel like we don't have much opportunity, but I've gotten a couple positives.
I just do it when I have like either possibly a resident or a fellow with me, but I don't eventually do it. I mean, again, we're spoiled, so they just go right away to the ultrasound suite and get it done. So, especially because, we don't look for the small ones, which they do. So if I have learners with me, then I'll do it just for educational purposes.
Yeah, we do not have the luxury of them going straight up. This is Adam from NBI. It's just, you have very little patient substrate who is at risk for DVT, but if there's a suspicion, we'll do them.
Nice. All right. Next case. So I've been trying to do a little more musculoskeletal ultrasound. So this was a 3-year-old with right leg pain, no medical problems. 2 days prior, he had complained that there was pain in both of his legs, but seemed to be fine and was walking fine. But then the morning that they brought him in, he had woken up screaming. He wouldn't walk or bear any weight on that right leg. And first he was, telling his mom it hurt somewhere in his hip or somewhere in his knee. And now in the ER, he's telling us his lower leg. So a pretty typical 3-year-old story that it hurt somewhere in his right leg. They hadn't noticed any fever. He had had no recent illnesses before that, no tick bites that they knew of. And on his exam, not too much helpful there. He had no fever, still wouldn't bear weight, was telling us it hurt in the lower leg, but there's nothing obvious. There was no swelling at the knee that we could see or any tenderness. And it was kind of hard to get him to move the leg anywhere. It seemed mostly like even when we tried to move his knee, it did seem like maybe it was his hip that hurt. So, so I grabbed the ultrasound, and so this is the side that's hurting him, and here's his right hip. So you can see a nice little effusion there. And then, oops. There we go. And then here it is with the measurement. So that was about 7 millimeters on the right side. And then here's his good side, the left hip. As you can see, normal looking on that side, no effusion. And I want to put in images as well. I had a similar, similar kind of presentation, hip pain and limp, afebrile, also on the right leg, a similar kind of age. And this was my ultrasound there. So just a little bit of fluid on this other patient. And then here is, there we go. Here's the contralateral side for this other patient. So really nothing on the other side. Then I've got a side-by-side on this patient. So I was curious what other people are using for the cutoffs with this. I mean, clinically for this patient, it did seem like his hip was hurting him. So I figured that this was real, that this was a small effusion, but it seemed like it didn't quite meet the criteria of like 3 millimeters greater than the other side.
I use greater than 5 millimeters or 2 millimeters greater than the asymptomatic side, I guess.
Okay. Yeah, well, I guess it's almost that. That's about 2. This is about 2 millimeters greater than the other side. It also did have that little bit of a bulge there too, along the femoral neck.
I use the same numbers, but the other thing I've been seeing a lot lately is people having variation of whether you measure the fluid pocket itself or out from the bone to the full capsule, which makes a decent bit of difference. You'd add probably another, certainly millimeter, probably a half on that if you're using, what measurement site should be for the corresponding cutoff.
Yeah, that's a good point too. Like this, you can see I just measured the fluid on this one too, right? That would definitely be another 1 to 2 millimeters there.
I agree, Matt. I think I sometimes see radiologists measure it differently, but I measure from the posterior border of iliopsoas down to the femur, and that may, yeah, I agree.
Yeah. So for this patient, I got a Lyme. We have a lot of Lyme in our areas. A lot of you probably do. That was negative. I didn't do other labs given that he was afebrile, and we did get him to walk on it a little bit after some ibuprofen. And I got x-rays, which were negative. I was rather annoyed. Our radiology, we have everything shared with our adult ED, so x-ray takes quite a while. So we got right in there and did this ultrasound. We had our diagnosis. It was great. We were going to send him home, and then I get x-rays, and like 2.5 hours later, we're finally getting x-ray results. So I had just shortly after seeing this patient, I came across this retrospective study from Boston Children's. I thought it was a nice, it's small and retrospective, but I thought it was interesting. And they looked at the yield of x-rays for children with hip pain with and without hip effusions. And they had 68 patients with hip effusions that had x-rays, and none of them had anything found on the x-rays. And out of their patients without hip effusions, they had a few abnormalities on x-rays, just 2 patients. So I thought that was interesting, and that kind of supported, I thought, at least my assertion that maybe I should have just skipped the x-rays and sent him home. So that was cool.
Kate, when you go back to your images, it almost looks, I'm used to it looking more like tapered versus, and I don't know if anyone has any comment to that, but I'm not used to it like ending so kind of abruptly, if that makes sense.
Yeah, I'm not sure. Here's the video clip again.
Like I feel like he usually tracks down the leg and doesn't, stop so acutely, but it might just be the angle or.
Yeah, it could be the angle too. Because you know what, actually, it probably is. Well, I've got the femoral neck that you can see the bone well, like at the beginning right there. So, I don't know.
And to your point, Kate, I just want to see if people were routinely getting x-rays. That's I haven't read that study yet, but interesting whether people are getting, if there's seen a fusion, how many people are getting x-rays on top of that.
I think it would have to be like if there was a concern for fracture.
Mhm. Yeah, and I really had no concern for fracture in this patient. So I think in retrospect, after seeing this study, I would probably skip the x-rays for a patient like this. I did look up, and potentially one thing that you'd be missing, even in a patient with a hip effusion, sometimes with leg cavity PERS, you could see a hip effusion, but it's also not, if it's that early in the diagnosis, your x-ray might be normal anyway. So I don't know that it's really that critical of a thing to x-ray in the ED if you have a small hip effusion and you're going to treat it supportively. So, yeah. Okay. Next one. So this is a 2-week-old male with a lump on his neck. He was healthy full term. They didn't notice a fever. The parents were reporting that it was red. It was kind of hard to tell. We were using a Nepali interpreter. I don't know how much of it was lost in translation, but they seemed to think that like this bump was bothering the baby. They said he's fussy, but then they're also reporting kind of like maybe his belly was bothering him. So it honestly just seemed like they're kind of reporting normal baby, first time parent kind of symptoms, that he was fussy and doing this and that. But so he's got this lump. They said they haven't noticed any trouble breathing. And then looking at the baby, so he was afebrile, he looked fine. There was this firm mass on his right anterior neck. It did not look erythematous. It wasn't fluctuant. And we noticed he was holding his head like just kind of turned to the left side. And it was pretty subtle. It seemed like something, the parents said they hadn't noticed it. Although when we asked him, they're like, yeah, he keeps his head to that side. But it just looked like he was laying there to the side. It wasn't like the rotated kind of thing. But when he tried to turn him to the other side, it was hard to get his head much past midline. So it seemed like a torticollis, but it was just weird that they were reporting that it looked red, and then it wasn't quite that like classic head tilt. So we grabbed the ultrasound, and I hadn't done this before, but it seemed like it should be pretty straightforward just looking at the muscle. So this was his good side, the left side, and so you can see at the top of it that you can watch the sternocleidomastoid here. So coming down, it's just like homogeneous throughout. It's pretty thin. So for comparison, and now here comes the other side. So here's the other side. And so this is the sternocleidomastoid there. And you can see compared to the other side, especially when you get right here toward the end of the clip, like here it looks brighter, hyperechoic compared to the other side. And at the beginning of the clip, you can see like the striations in it. So this was definitely in the muscle, but pretty significantly enlarged, just the whole muscle belly compared to the other side. And it was a little more so at the top part of it, but pretty much the whole way down, it was still larger than the other side here towards the more distal end of it. So yeah, so that confirmed our diagnosis of torticollis, and with the name for the mass being fibromatosis coli. And here's another just radiology picture from a different patient of that, just showing the asymmetry in the two sides with your normal, nice, thin sternocleidomastoid, and then the other side with that enlarged area, a little bit hyperechoic, which is pretty typical in appearance. And here's another one as well, looking more similar to my patient with just that big enlarged muscle. And then the one thing, so I did a little reading on this, just, so I was kind of prepared for what I was looking for, thinking that if it had been red, maybe it was some kind of cyst. One thing we didn't check to see if it transilluminates, which might have helped if it was a cyst. But so here's an ultrasound picture of a cystic hygroma, which could be another thing seen in that area. And you can clearly see the difference with that kind of loculated cystic appearance to it. Questions on that one? All right. So next case, this was a 2-week-old with fever. They had a fever at home to 100.4 rectally. They had a little bit of cough and sneezing and had fed a little bit less that day, but overall seemed well. They didn't think she was acting lethargic or anything crazy. And her older brother, like a 3-year-old brother, also had fever. And the baby was healthy, full term, no problems, and no like perinatal complications, antibiotics, nothing concerning on mom's labs or anything like that. So being, you know, a 2-week-old with fever, our plan was to do the whole workup, the blood culture, urine culture, LP, and doing our thorough baby exam. She looked well. She was afebrile in the ER, but just on our exam, we get down to her back and you see this little dimple at the top of the gluteal cleft there. And even when you kind of pull it apart, you couldn't see the base of it, so it looked like a pretty deep dimple there. Otherwise, though, it looked like the gluteal cleft looks symmetric. It seemed like neurologically she seemed fine, was moving her legs, good reflexes. And the parent had not noticed this, and I guess it hadn't been noticed or paid much attention to in the nursery. So she had not gotten an ultrasound, or it seemed like there was no plan to do so. So you can probably guess where this is headed, but I am curious, would anyone, I don't know, would you proceed with LP, do anything different?
I would proceed.
So I was a little,
and then I tend to use ultrasound.
yeah. So you know, I was a little nervous about doing an LP in case there was any spinal cord abnormality. So I unfortunately don't have my point of care images. I hadn't saved them, but you know, I put it on there and didn't think it looked quite normal. So just sent her down for a radiology ultrasound. And the radiologist was a little confused. He's like, "Tell me why we need an emergent spinal ultrasound." I was like, "Well, because I don't really want to do this LP." So here's one of the radiology images, and you can see, so they labeled L5 down here. So you'd be going like in this area here, L4 to L5, or you know, potentially even L3 to L4 would be bad on this patient. So you can see the conus here. It really terminates like around the level of L4. And the other thing too is that with this, just so this is a tethered cord, and you can see there's really like no CSF in that pocket where you'd want it to be, even if you went at L4 and L5 and we're just below the conus, there's just no CSF there. And I think you can see it even better on the transverse views in terms of the pocket you'd be going for and the lack of CSF there. So this is on the right was a normal one that I did just routinely before ultrasound. And this one had a nice big pocket of CSF. And then on the left is the infant in our case here with the tethered cord. And so you can really see there is some CSF actually like here, but that would not be where you're going. That's for the LP. So yeah, so we did some labs on this patient instead. Unfortunately, you know, we were pretty convinced that she probably had a virus anyways, and she looked well. So white count was normal. You know, I didn't usually do CRP and things at that age because you're just doing the full workup, but we did those and that was normal. So we got her admitted, and the pediatrics team watched her without antibiotics, and she did fine. But so she did end up, and then they consulted neurosurgery, and they didn't do it right away. I think they did it closer to age 1, but she did then get a surgery and release of her tethered cord. So I thought that was pretty interesting. I didn't want this case, you know, complications from LPs are so rare, and we do them all the time without imaging. And I didn't want this to be, you know, that one zebra that made me nervous to do LPs forever. But, you know, but I have been doing spinal ultrasound just to look for your landmarks and look for your best CSF space before LP for infants. So here's one video clip of the transverse view in a normal infant. I just thought this video was really cool. I said, I've heard some residents try to explain to parents about like the cauda equina and that they're just floating around in the CSF, and it'd be like trying to catch a spaghetti with a fork in a pot, and you can really see the nerves kind of moving around in there. That was cool. And so here's a view. So what I typically do just to find your landmarks, this is a normal one, and you can see the conus. I didn't mark out what level this would be, but I think this was about L2. And so just find that conus there and mark on the baby where it is so you don't go up that high. And you can see on this one, there's a nice CSF pocket. And then at the level that we're going to go, I'll measure the depth and then actually mark that on the needle. Our LP kits have a sterile marking pen in the kit, and the manometer is 1 centimeter marking. So I've just been using that to mark the depth, so that especially when there's a resident doing the LP, I can be watching and know that they haven't gone too deep watching the needle. So, and I know there were some studies on this, that doing the ultrasound to look for landmarks and mark the depth definitely improves success for LPs. So I was curious if other people are doing this as well.
Okay, yeah, definitely, especially if I have like residents, just because like you said, it helps me sort of guide them how deep to go. And then on difficult ones, whenever I'm teaching, they also are very pleasantly surprised when you actually mark it, that the marking actually works. So I
Yeah,
tend to use it a lot.
it's cool. Yeah, I really like it. I feel like it's
Yeah.
been a little bit reassuring for parents too, when you're like, hey, but I'm going to take a picture first to make sure everything's okay and this is a good spot.
Yeah, and Henry, I sort of do it some way. I use it more largely for teaching, showing the space. I'll have the residents sort of show me where they would go from a palpation side. And then I find inevitably the residents go far lower than I'm willing to go. And I show them what the space is where they're at versus how high I would be going, to give them a much better target. I also like throwing it on transverse and showing them the epidural vessels, because inevitably they want to like airplane off, to side.
Yeah.
So it's kind of showing them why they got that traumatic tap. I've also started, and this is more for some NICU stuff, doing a quick head ultrasound on all the babies I tap, not expecting to see anything, but more to just get used to looking at normal brains from the time I actually care.
Oh, nice. That's a great opportunity. I haven't done any infant head ultrasounds and I've been wanting to, but while we have it out for an LP, that's a great idea. So yeah, like you mentioned with the vessels, so here's a video clip of that. And so you can see those vessels off. So this one, it looks like the pretty standard anatomy for where the vessels are. I saw an interesting case report too, that they did one and the vessels were like right in the way of the spots. They were like more in the midline and right in the intervertebral space, and they couldn't find a good space that didn't have vessels. And they tried the tap anyways and got a bloody tap. So I thought that was interesting, but that hasn't been something that I routinely look at. Like for my purposes, I've just taken this, like you said, just to show the residents where they are. And I had one interesting one that a colleague of mine had tried the LP and it was unsuccessful. And I was like, well, I'll take a look and try again. And so I took a look and there's like barely any CSF. And this was up at like L3, L4 that I was getting a little bit of CSF. So I tried it at L3, L4, and I got literally like a drop of CSF, and that was it, like not even enough to culture. So I thought that was interesting that it kind of correlated with what I was seeing on the ultrasound.
Looks like you've got some hematoma at some of the lower area, probably from
Yeah,
fire.
I think agreed. Yeah. So I'm pretty sure that's where they went before. Yeah. Nice. So next case, I have a 16-year-old female with a headache. Her medical history, she has hypothyroid, depression, PCOS, obesity, and acne. She was on Synthroid for the hypothyroid, minocycline for the acne, and OCPs. She's had about 2 weeks of headaches with some neck pain and upper back pain. She says she's feeling dizzy. The headaches are just pretty constant, no vomiting with them. And she didn't really report any positional changes with the headaches, but they just in general won't get better. And she's now having some vision changes. She described them as like triangles that she's seeing in the middle of her vision, as well as some peripheral vision loss that just kind of comes and goes. It didn't seem to fit like a migraine or a kind of pattern that these triangles were appearing and then disappearing and then getting a headache. They were just kind of, she said they were there like all day on the day that we saw her. And then otherwise review of systems was negative. She had been to her ER the prior week. She got a migraine cocktail. She was doing better. She got a head CT that was negative. And it didn't seem, there wasn't too much mention of the vision changes at that point. And this is a bit of a spoiler alert, but I think the ultrasound is still good. That the reason she came back to the ER today is that she saw an optometrist to get her eyes checked, and they saw papilledema as the center in. And so looking on our physical exam, you know, it was a little difficult without dilated pupils, but you definitely could see papilledema, I think probably about grade 2, although I don't know if an ophthalmologist would feel differently. And cranial nerve exam looked normal, otherwise it seemed fine. So I just always like confirming this diagnosis, confirming the papilledema with ultrasound. So this is her ultrasound. Her left eye definitely enlarged optic nerve sheath diameter at 5.9 millimeters. And you can see a little bit of elevation of the optic disc here in the back of the eye. And then other side, not quite as big. So 5.3 millimeters on the right side. And same thing, a little bit of that bulge. So I was curious, I looked up the literature again, because obviously the 5.9 is definitely elevated. And on exam, she did have papilledema in both eyes. It seemed like I found numbers ranging from anything of like 4.5 millimeters to 5.9 millimeters. What are you guys using as a cutoff, or at least, you know, where might you be concerned?
I use 6 millimeters.
Yeah.
You know, so because between 5 and 6, I have some negative, false positive. So 6, I feel like that's the number I've used.
Okay.
Henry, based on that, I forget who was the guy who gave us that talk last year.
Aaron Chen.
Kate, if you go to the previous one,
Yeah.
I think he might argue that the left caliper, because he was kind of insinuating that you want to find the actual edge of the sheath, and I'm wondering if he might have marked
like
it
the
a little
sheath
more to the
here.
right.
Okay.
Yeah.
So not even quite as big.
But I don't know if other people agree, but you know, I think that was one of the points he was making.
Yeah.
Yeah, and a little further down, you can see the sheath better. Like on the right, you see that the outside of the sheath, like you said, that would be in from where I measured.
Yeah, I've had some pretty long discussions with Aaron on this, because I sent him a bunch of our path to try to add to their image repository, and he's far more brilliant and versed on this than I will ever claim to be. But the short answer is this is like a nightmare of a measurement. It seems like there was this recent like neuro-opto paper sort of meta-analyzing all the different ways this has been reported and measured, and it's just all over the place. I think Tesaro, the sick kids group, just had a paper out on PEDS optic disc elevation, which I think looked like it performed a little more reliably and is a little less subjective. And there was actually a fellow lightning talk at SCUF a couple weeks ago. I think it was a guy in Wisconsin. It was adult based, but they were comparing globe diameter to optic nerve sheath diameter as a normalizer. And I think their cutoff was like 0.25, and anything that was greater was elevated. Anything that was less was normal. And this was like a 5-minute lightning talk, so the fine details are very much lost. But they said that it sort of crossed over and wasn't affected by height, weight, BMI, all kinds of like biometrics that you think might change. So I've subsequently emailed to try to get more info from them, not heard back.
I don't know if it's the same article, Matt, but they just had a ultrasound gel junior podcast on this topic. That was actually pretty interesting, and they were talking about the disc elevation.
Yeah, I'm pretty sure that was the Tesaro paper.
I'm sorry.
I'm pretty sure that was the sick kids Tesaro paper that came out.
Yeah, I think that's right.
Nice, thanks. Yeah, so that was the next image I have here. I didn't find that newer paper. This was from 2013. This wasn't it was in an emergency medicine journal, so adults too. I think in our image here, we just a little bit overestimated the height, but definitely still high, and you can see that big bulge there. So this is like 1.8 millimeters on ours, so definitely elevated there. And in this paper, they said less than 0.6 millimeters is normal, 0.6 to 1 was borderline, and then greater than 1 was always abnormal. So yeah, I don't know if that'll pan out to be a better marker than the optic nerve sheath, but I thought it was interesting that you can at least put together those couple pieces of information. So she got an MRI and an MRB. They did appreciate some optic nerve swelling on that, but otherwise it was normal. And so she got an LP, her opening pressure was 42. And so she was started on Diamox, and she had a bunch of risk factors. She was on minocycline, she was on OCPs, she had obesity. So she had a bunch of risk factors for idiopathic and cranial hypertension. But at last follow-up, this was pretty recent, but it seemed like she was improving on Diamox. And I think they got her off the minocycline too. And one more case. So the last case here is a medically complex 5-year-old with fever and respiratory symptoms. Her history, this isn't her entire history, but overall picture is she has hydranencephaly, seizures, developmental delay. Her baseline kind of, she's not especially interactive, just kind of smiles and doesn't move too much. She has a BP shunt and a G-tube. And she's had a bunch of random infections, various things, has myringotomy tubes. So she presented for this illness with fever, tachypnea, and lethargy. I think their biggest concern was her breathing at home. And she had actually just recently been admitted and intubated. In the ER, she was febrile and tachycardic, and she was tachypnic. There's really nothing other than that remarkable on respiratory exam, but just doing a thorough exam on her. Her abdomen was really tender in the left lower quadrant. I kept watching the resident examine her, and left lower quadrant, she would just wince and jump and was guarding there. So we grabbed the ultrasound, and okay, so here, this is in her left lower quadrant where she seemed to be tender. So when we first put it on, you can see it looked like the bowel there was a little bit edematous and maybe some inflammation around it. It's a little hyperechoic there. And so then following it down, so you start to see some more inflammation, and then the shunt catheter. So I'll pause it. And so here, definitely like some inflammation in through here. And then you start to see the shunt catheter pop in up at the top of the screen here. And then there's this collection just below it. So here it's a little bit echogenic in there. And one more of this. And so here it is again, that collection like right under the shunt tubing there with inflammation around it. So we figured that this was an abscess. Open just one more, there we go. So, oh, and I threw in, I had saved the image, so I just threw this in here as well. So she didn't have good veins at all, and her extremities were kind of swollen. So she needed an ultrasound IV, and this was actually the best vein that we could find. It was probably about a millimeter or two. And I was really proud. One of our second year EM residents wanted to do it, and he's like, I can get that, and got it on the first try. So that was good. And it was a weird vein too. It was like on the back of her arm like this. We had to hold her arm up to do it. And I just wanted to throw out there, if so we used for this tiny little vein, we have these 22 gauge long IVs, 1 3/4 inches. If anyone doesn't have them, I highly recommend this. I think there might be another brand now that has something this length too, but when we first got them, this was the only thing available. And it totally changed things. There's a paper from adults that the longer the catheter that's used, the longer the longevity of it. And before we got these ones, I was using, if it was a vein this small, I'd be trying to use your standard like 22 gauge 1 inch IV. But these seem to last a long time and are small enough to get into tiny veins like that. So they're pretty awesome. But yeah, so back to her abscess. So her white count was elevated. Otherwise, her labs looked okay. Her chest x-ray just had some atelectasis. And so she got a CAT scan and confirmed that there was that abscess there. You can see it's about like 2 by 3 centimeters right where you're seeing it. And it looks like her shunt tubing is just kind of, it's really just hugging the shunt tubing there. So she went to the OR and they externalized her shunt to get away from that abscess and left the shunt external for a good week or two before putting it back in. They drained the abscess and treated her with IV antibiotics for a while. And that is all.
Those are great cases, Kate, and good discussion.
thanks.
So thank you.
Kate, I threw that Tesoro paper in the chat. Hopefully it can be downloaded from there.
Oh, awesome. Thanks.
Yeah, thanks. Matt, I downloaded that as well. So yeah, but once again, thank you, Kate, for presenting, and looking forward to have you again in the future. And thank you. And thank you everybody for coming to the chat this week.
Thanks, everyone.